pass through the mouse, then you can play around. Okay.
A very good evening, ladies and gentlemen. Welcome to this next installment of Cancer and I. And this is our ongoing series in line with World Cancer Day, which happened on the 4th of February, 2021. And we've had a couple of very interesting sessions so far. And today, we're very fortunate to have with us a series of esteemed consultants from our partner for this session, Assumpta Hospital in Petaling Jaya. And together with me this evening, I will have three very senior esteemed clinicians who will be speaking about various different aspects of cancer management, which has been part of what this series is. And kicking off this series, which very interestingly we have named as Hormonal Horoscope. And the reason for that is very often we're always not very sure about really, is there a relationship between a lot of hormones and cancers? Do hormones cause cancers? Hormones worsened in cancers? And what about cancers in those glands or organs that actually work at producing hormones? So we're going to get some very interesting insights this evening onto this. And I hope you all have settled down, though, since it's the first day of actually a lot of back to work. A lot of people are back to work. So if you're driving back to work, there's a huge jam in KL already. I hope you're tuned in to your Facebook Lives and you're putting this on audio so they can listen to it and get some insights as you're driving back home. For those of you all who have settled in for dinner, this will be a very interesting dinner conversation. And this evening, our first speaker is an esteemed surgeon. In fact, there's very few people in Malaysia who do not know Mr. MMS Krishnan, who is a consultant general surgeon. And I will, for how to say, for the rest of the session, call him Prof, since I'm very used to addressing him as a professor. And Prof Krishnan is, for a very long time, was with the University of Malaya as well. Like I was saying, Prof is most likely has forgotten more about surgery than the rest of us will ever learn in our lifetimes. Good evening, Prof. Thank you very much for joining us this evening. Such a pleasure having you.
Good evening, Dr. Murali. Same here. It's been a pleasure to be here this evening.
Oh, lovely, Prof. And today, Prof, we've got you for, I think, to speak about one of the slightly not so common cancers, but I think something that's very important for a lot of people who suffer or have to live with these cancers, which are cancers of the thyroid gland. And we often kind of take the thyroid for granted. We seem to think that, you know, everything runs well and we don't notice when something does go wrong. So we're hoping that today you will be kind of able to share with us, provide us a very detailed view into and basically read the horoscope for us of the thyroid gland, Prof. So I'm going to turn the screen over to you, but just before we start on that, I don't know whether you've noticed we always ask one or two very interesting questions to kind of get some input into the person who is Professor Krishnan. And after this very long and esteemed career, Prof, in surgery, what gets you every day when you get up in the morning? What is the aspect of surgery that really continues to drive you every day?
Well, Dr. Murali, I suppose that is a question that many people have been asking me about what makes you drive. I suppose this has grown into me. It's gone into my genes now. And I think that's how I've been in this career for since the early 1970s. And so that speaks for nearly about how many years now? It's going to be 5 decades of surgical experience. And I've been living with surgery for 5 decades.
Right. So
but I'm not tired yet. I'm not tired yet. and hopefully that's how it goes anyway.
Does it continue to be interesting, Prof? Do you still see interesting cases, or is it things like when you see it, like I have seen 200 of this?
I mean, the thing is like this, there's not a day that which I think without a surprise. You can say there's so many things that we learn each day. And I suppose even after so many years, there are occasions then I have to learn certain things. That's what happens.
Right. Oh, lovely, Prof. Lovely. That's very inspirational for the rest of us, because it just tells us that look, there's still a lot more for us to continue learning and doing, and learning by doing, and really hopefully one day be able to walk in very far away from your footsteps, probably in the next next beach. So we're coming to thyroid cancer, Prof, and I'm going to turn the screen over to you to speak to our esteemed audience this evening, our viewers, on thyroid cancers and what they're all about. Over to you, Prof.
Thank you, Dr. Muralidharan. Today I'm going to speak to you about thyroid cancers. And my first slide here is to tell you what a thyroid gland is. Many people do not, they think thyroid, they come and tell me, I've got thyroid. But what it really means thyroid? They mean a thyroid gland is a gland that lies in the front of the neck. It's covered by a few muscles in the front of the neck. And as you see here, it's butterfly shaped. It lies in front of the windpipe. There's the windpipe here. And that's butterfly shape. It has got two sides, the right and the left lobe, which is connected by a bridge of thyroid tissue. In a normal person, one cannot feel the thyroid gland. It's so thin and it's less than about half a centimeter on each side as far as thickness is concerned. So you cannot feel a normal thyroid gland. The thyroid gland is very close to the voice box, as you see here. This is the voice box. And the nerve that is going to the voice box is very close to this windpipe, goes behind the thyroid gland, sticks to it, and enters the voice box somewhere here. That is an important structure for all surgeons who deal with thyroid problems. Now, what is the thyroid gland? A thyroid gland is an endocrine gland. When we say an endocrine gland, it means it has no duct. Whatever secretions that the thyroid gland produces, it goes directly into the bloodstream. And that's why it is called a ductless gland or an endocrine gland. So it has got functions. The function is because it produces certain hormones, especially known as triiodothyroxine and tetraiodothyroxine. And the tetraiodothyroxine is the final product, but the triiodo is also an active hormone. So this hormone is necessary for our body's metabolism. Every cell in our body requires this hormone to function. For example, it controls our heart rate, it controls our blood pressure, it controls the growth of our brain when you are young, in a baby, in a fetus, and even in childhood. So this is a very important hormone for the functioning of every cell in our body. Now, if there is too much of production, we call a condition known as hyperthyroidism. And what happens in hyperthyroidism? Common symptoms are the patient becomes very anxious, sometimes restless, the heart beats very fast, sometimes it is irregular, the patient would feel palpitation, there will be sometimes increased sweating, they could have, they feel very tired sometimes because of the increased metabolism, they sometimes lose weight. In some patients, you can get the eyes become very prominent and we call it exophthalmos. What happens when it does not produce enough hormones is called as hypothyroidism. And in here, what happens, the patient has got a puffy face, the skin becomes very dry, they become very lethargic or they have no interest in doing anything, they cannot tolerate normal, they feel very cold, they will the heart rate becomes slow, and that is some of the features of hypothyroidism. These are the functional aspect, and when there is dysfunction, is either hypothyroidism or hyperthyroidism. The other medical problem that can occur with thyroid is structural or morphological changes. That means you can get swellings in the thyroid. The swelling can be single or multiple swellings, or the swelling of the whole thyroid can be uniformly enlarged. So this is what happens. Now, when you have structural problems, that means we need to know what is wrong. Sometimes along with structural problems, the function will usually be all right, normal. Very occasionally, you might have a swelling in the thyroid with increased activity or decreased activity of the thyroid gland. The female gender is known to have a higher incidence of thyroid problems. It is about 5 to 8 times more than the male gender. Now, this is an example, a picture of a lady who has got hypothyroidism. That means it's producing less of hormones. And you can see the face is very puffed up, the skin is very dry, she's got dry hair and very brittle and just pouting lips. This is another picture that you see here of what we call as hyperthyroidism. And you can notice here, this lady has got a very prominent staring gaze because there is a protrusion, slight protrusion of the eyeball. And you can also note that she's got a uniform enlargement of the thyroid gland, and we call this as Graves' disease. And it is due to hyperproduction of the hormones. Now, coming to structural issues here, as you see, as I mentioned, you can get swellings of the thyroid. And here in this picture, you can see multiple nodules in the thyroid gland. And this condition is known as multinodular goiter. And here on this side, you can see a single nodule in the thyroid gland. You call it a solitary nodule. This nodule can either be solid, it can be cystic, that means it contains fluid, or can be a combination of both solid and fluid together. This condition, either of these conditions, can be either cancerous or non-cancerous. Now, let's go to thyroid cancers. What are the risk factors in a person to get thyroid cancer? The female gender, as I mentioned, has got a higher tendency than men to develop thyroid problems, especially thyroid cancer. The commonest age group is between the age of 40 to 50 years. And in the male, it's usually between the age of 60 to 70 years. Radiation exposure over a period of time leads to a higher risk of thyroid cancer. There are certain thyroid cancers which have got inherited genetic syndromes. And that especially you can see it in medullary carcinoma, which is a type of thyroid cancer, which I'll come to a bit later. When a person has got a history of goiter, goiter means any swelling of the thyroid gland is known as a goiter. A person who has got a family history of thyroid goiter has a higher chance of developing thyroid problems. When a person is in an area where there is a deficient iodine in their diet, in that area, it has been known because of the prolonged deficiency of iodine in their diet, the risk of developing follicular type of thyroid cancer is higher. Any breast cancer patient who survives more than 5 years has got a tendency of developing cancer of the thyroid a bit higher than the rest of the population. Now, what are the different types of thyroid cancers? There are, as I mentioned here, the papillary cancer. Papillary carcinoma of the thyroid is a picture here. Can you see? There are some papillary processes like fronds-like structures within the thyroid gland, and that is what you see. And that condition is known as papillary cancer of the thyroid gland. This is the commonest cancer that one sees, and usually seen below the age of 40. Majority of them cases are below 40. It can occur in higher age groups also. The commonest way of spread for this cancer is through the lymph nodes. And this cancer has got a much better prognosis than all the rest of the type of cancers that I'll be coming to later in the thyroid cancer group. The follicular cancer occurs in an older age group. And that, an example, you can see the thyroid gland here. There's a solid lesion, as you see here, a bit fleshy. And that is an example of follicular cancer. They occur in the older age group, and the spread is usually to the lymph node and also to the bloodstream. The next one is the medullary cancer. This cancer can occur in families because it carries a gene known as the RET oncogene. And those people who have got this gene have got a higher incidence of developing medullary cancer. Sometimes it can occur sporadically. That means there may be no family history of that, and still the patient can develop medullary cancer. The medullary cancer occurs from a separate cell in the thyroid gland known as parafollicular cells. I'll come to it later and explain certain features of medullary cancer. The anaplastic cancer is the most aggressive type of cancer, and it occurs for people who are above the age, commonly occurs above the age of 60 years. It spreads rapidly through the bloodstream, lymph node spread, and directly to the surrounding structures like the nerves, going to the vox voice, also to the windpipe, and also to the food pipe as well. And the last, this is the least common of all, is the lymphoma of the thyroid gland. This is usually a part of the blood problem, and it is arising from the lymphoid tissue of the thyroid gland, and that is known as a lymphoma. Now, what are the signs and symptoms of the thyroid cancer? Any person who has got a lump in the front of the neck, I mean, when I say front of the neck, it is this area of the neck, the front of the neck, one should suspect and one should rule out whether it's a thyroid gland or arising from the thyroid gland or not. The characteristic feature of a thyroid swelling is when you ask the patient to swallow saliva or drink water, you'll find the lump going up and down. That means the swelling is arising from the thyroid gland. If the patient has got hoarseness of voice, again, that's one of the symptoms of thyroid cancer. Difficulty in swallowing because of pressure on the food pipe. Difficulty in breathing can also occur because of pressure on the windpipe. Pain in the throat is another symptom. Unexplained cough going on for a long period of time is also a feature of thyroid cancer. Sometimes patients will have no symptoms, just a solitary swelling in the neck of no significance. They would say, I've had this swelling for some time, maybe 3 months. I just noticed some of my friends noticed it, and then they asked me to. And that's how I come to see and evaluate. So sometimes it's just an incidental finding with no symptoms whatsoever. How do we diagnose it? First, we have to take a proper history and then do a physical examination, find out the size and the nature of the swelling, how it is firm, whether it is fixed to certain structures of the neck. Then a set of blood tests is done. First of all, we should do a blood hormone level of the thyroid glands, which is a 3, T4, and that will tell us whether it is normal. The TSH is another hormone that is produced in the base of the skull from the brain, known as the pituitary gland, and the hypothalamus gland also. Hypothalamus of the brain also is involved in controlling the thyroid hormone. The thyroid stimulating hormone, which is produced by the pituitary gland in the brain, controls the secretion of the thyroid hormone. Thyroglobulin is another blood test that we do to see the activity of the cell. It's not very specific for cancer. It can occur even in patients with hyperthyroidism and also in patients who have got autoimmune thyroiditis. Then the thyroglobulin antibody also is a test that is done. It interferes with the thyroglobulin when the antibody is present. And if you suspect medullary carcinoma, we need to do serum calcitonin and carcinoembryonic antigen, which are raised in this type of cancer. of the thyroid gland. Then next, of course, we have to, once you make a diagnosis of medullary cancer, you need to do some genetic studies to see whether this patient has got the RET or congene. And that will help us to look at the family and do certain tests to see whether this gene is present. When that is there, we need to do some counseling and further management of the patient's family. The most important investigation for a patient who has got a swelling in the front of the neck, the thyroid gland, is the ultrasound. And an ultrasound examination by a proper radiologist will be able to give a lot of information on the nature and the status of the thyroid gland and what the probable diagnosis could be. To confirm the diagnosis, we need to do a biopsy. A biopsy can be done by passing a fine needle into the swelling of the thyroid gland. And this is usually done if the nodule is very small and you cannot know exactly where it is. It's by means of an ultrasound, and an ultrasound guided aspiration would give a more definitive diagnosis, because they can take out adequate amount of specific cells so that the pathologist will be able to give us a proper diagnosis. However, there's a 40% failure of getting adequate cells for the pathologist to give a diagnosis. So a negative aspiration of cytology does not mean anything unless you have to correlate it with the clinical features and the other investigations. The next test is known as a core biopsy. Here, again, is a needle with another, which takes a thicker tissue of thyroid tissue, and that is more useful for the pathologist to make a definitive diagnosis. Of course, if you make a diagnosis of cancer, then of course there's molecular testing as well. Once the diagnosis is made, we sometimes do a radionucleotide test just to see whether it's a cold nodule or a hot nodule. The next is a chest X-ray to see if there are any metastases in the lung. A CT scan is done only if you think the size of the tumor is big and whether its relationship to the windpipe, the food pipe, and also whether it is pressing against the veins in the neck, and whether the tumor is extending into the chest. The next one is, of course, if you want to see the spread of the disease, is what we call it a PET scan or a CT scan. And this is basically done to stage the disease. What is the treatment? Ideal treatment for thyroid cancer is a surgery, and that is a thyroidectomy. When we say thyroidectomy, it can be a lobectomy. That means you remove only that part of the lobe. That is, if it's right side and if it's only involving the right side, you can excise the right side along with the nodule. And while we excise it, we also use a facility known as frozen section. That is, while the patient is still in the operation theater, that specimen is sent off to the pathology lab, and there the pathologist will be able to do a rapid frozen section study and will be able to inform the surgeon whether this is malignant or not. Here again, there can be failure because certain type of cancers of the thyroid gland cannot be detected by frozen section, especially the follicular variety, which the diagnosis is based on whether the cells have infiltrated beyond the capsule of the thyroid gland or entered into the blood vessel, which is very difficult to detect on a frozen section. So a negative frozen section does not mean that the patient does not have cancer. The pathologist needs to get time, maybe after a week, when the proper paraffin sections are done, then only the proper diagnosis can be confirmed. But a positive diagnosis on a frozen section is always positive because the pathologist will never give a positive diagnosis unless they're 100% sure of that. If you do only a lobectomy, then of course, there is the other part of the thyroid gland is still there. Now, one of the reasons why surgeons prefer to do a total thyroidectomy is because of multifocal chance of developing tumor. So tumor, even though it's in one part of the thyroid gland, there be other small foci in the rest of the thyroid gland where there could be malignancy. And hence most surgeons prefer to do a total thyroidectomy so that you can clear whatever risk of a multifocal spread. Especially if it's a papillary carcinoma of thyroid, the lymph nodes in the center of the neck, in front, above the thyroid gland, and below the thyroid gland, right up to the suprasternal notch, that is before it enters into the, before the windpipe enters into the neck, has to be cleared of lymph nodes. What are the risks of thyroid operation? The main risk is, of course, to the nerves, going to the vocal cord, and that ranges about 4%, but 1 to 4%, depending on how much of adherence of the tumor is to these nerves. Having done a thyroidectomy, it's usually appropriate to consider radioactive iodine therapy because there might be some foci of the tumor that has been spread elsewhere. And the idea of giving radioactive iodine therapy is because these tumor cells are very avid and like to take iodine wherever it is. So having done a total thyroidectomy, the patient is the hormone production is completely gone, and so the patient becomes hypothyroid. Hypothyroid means very little of hormone is circulating in the blood. So after operation, we leave the patient without any replacement of hormone for 4 weeks. When we do that, the thyroid stimulating hormone, which is produced by the pituitary gland, goes higher and higher. And we want to change that state. And after 4 weeks, the patient is ready for radioactive iodine. If the patient then takes radioactive iodine orally, then what happens? Because of this high thyroid stimulating hormone in the bloodstream, it absorbs all the iodine. Wherever there are cells outside, maybe in the lung or elsewhere, then when the radioactive iodine is absorbed by these tumor cells, it destroys this tumor. So that is why radioactive iodine therapy is given. That is, whatever residual tumor that might be present anywhere in the body, we can treat it by giving radioactive iodine therapy. This is very simple. It is usually given as an oral dose. The patient has to be quarantined in isolation for 48 hours after taking this. It has usually no side effects. It is recommended in women above the age of 45, but below the 45 years, in most centers, it's not recommended because there's a possibility that they might get pregnant, and so that we do not advise radioactive treatment in women who are going to plan to have more children. Now, external beam radiotherapy is only indicated in anaplastic tumors or where there is residual tumor in the neck. And that's where then you have to consider external beam radiotherapy. Chemotherapy is not usually prescribed, but then now, whenever you have patients who have got recurrent tumors or residual tumors, a targeted therapy with sorafenib and levantinib is now done. Now, having done a total thyroidectomy and then the patient has radioactive iodine, then the patient is started on thyroxine. Thyroxine replacement has to be tailored according to each patient's need. We cannot say what's the dosage for any patient, standard dosage. It has to be tailored according to the patient's metabolism. And we do that by doing regular thyroid stimulating hormone assessment and then prescribed thyroxine tablet. The thyroxine tablet has to be taken on an empty stomach first thing in the morning, and only after 30 minutes the patient can take any drink or breakfast because the adequate absorption is only at that time. After thyroidectomy, sometimes the parathyroid gland may be affected, and so the calcium levels can be down. So these patients also should be monitored for serum calcium levels, and if so, calcium needs to be prescribed. Serum thyroglobulin is done in these patients on a periodic basis to see whether the levels are rising. If the level of serum thyroglobulin in the blood rises, there is a possibility that the patient might have a recurrent disease, and then that has to be investigated. A thyroid scan is done at that time when you think that thyroglobulin is raised, and that scan is usually a PET scan to detect the recurrent tumor. Dr. Murali,
Thank you so much,
completely.
Prof. Thank you so much, Prof. That was very detailed and comprehensive. I think for a lot of people, we rarely hear about thyroid cancers, Prof, unless you're faced with it. So I hope that for viewers, this managed to give a very broad perspective, better understanding of thyroid hormones. Prof, if it's not too much of time, if you're okay for time, we've got a couple of questions. Questions seem to be coming in. Are you okay to take them, Prof?
Yes, sir.
Okay, lovely, Prof. The first question is on biomarkers, Prof. So there's a question on, is there a kind of, if you use biomarkers to screen for thyroid cancer, does that work?
Yes, especially if you have, when you suspect the medullary cancers. Now that has been more or less very well established, and with the ret oncogene is done. And so what happens if you find a person with a medullary cancer, the family, the close siblings and are brought in, the blood test is done, the molecular studies are done to detect this ret oncogene. Now, even if the patient is a teenager, I have had an occasion where even a teenager had to be operated because this ret oncogene was positive. So this is known as a prophylactic thyroidectomy. So even before a thyroid cancer comes, if the ret oncogene is positive, then we advise a total thyroidectomy. We call it a prophylactic thyroidectomy.
Okay, lovely, Prof. And that can happen at any age, because with the presence of a ret oncogene, as you were telling, the likelihood of getting a thyroid cancer is very, very, very high.
Very high.
Right, right. Will do, Prof. Prof, there's another question on, can we do just the thyroid hormone levels in a medical screening every year, and can that function to screen for thyroid cancer?
Mere testing of the thyroid hormone is not diagnosis. You can have thyroid cancer with normal thyroid hormone levels. That's it, yeah.
Right. And I think that's an important point that you're making for our viewers as well. A lot of us kind of have an idea that you just do a blood test along with all the other blood tests, add in your thyroid hormones, and then we seem to think that actually that forms as a kind of indirect screening mechanism for thyroid cancer. I think it's good to take heed of what Prof is saying, which is really that's not the case. So, and I think Prof was also saying, Prof, just now that quite a lot of people turn up very asymptomatic with a lot of growths, which lie very quiet for a long time, Prof.
Yes. When you have patients with multinodular goiter, especially that multinodular goiter, you can see people walking around with that for a long period of time and without any symptoms whatsoever. Here, multinodular, what are the chances? When a person has got this multinodular goiter, what are the risks of developing cancer? Here, the incidence of developing cancer in a multinodular goiter, that means where a person has got multiple nodules, is about 10%. So what happens? How do we manage this patient? It doesn't mean that all patients with multinodular goiter, we should do an operation. The operation is only indicated for multinodular goiter if there are pressure symptoms, if it's causing any symptoms. Otherwise, we do not advise, because if the thyroid hormone levels are normal, we just say, okay, you want to do it. Otherwise, for cosmetic purposes, we'll have to do that. Now, how do we manage these patients? It is, we have to do an yearly ultrasound to see if any of these nodules are becoming dominant. The term is a dominant nodule. We have to identify a dominant nodule. If the dominant nodule is becoming bigger and bigger, or an ultrasound shows certain features which are suspicious, that has to be biopsied.
Right. Well, Prof. And then, so there's another question on how do we decide on targeted therapy for thyroid cancers? Prof had mentioned something about targeted therapies. And so the question is there any test that we have to do in order to determine whether we are suitable to get targeted therapy?
Yes, I think there are some molecular studies that we need to do, which are more specific for the type of cancer that you can detect. And once it is detected, then the targeted therapy becomes more useful.
Right.
And that usually comes in patients with follicular cancers, especially, and also anaplastic cancers. Yeah.
Okay. Will do, Prof. Thank you. And there's a question on if we have removed the thyroid previously, will it come back? If yes, why?
Yeah, if thyroid has been completely removed, the chances of getting a thyroid problem again does not arise unless the patient has got some ectopic thyroids. You see, the thyroid gland is or development is from the floor of the mouth. The thyroid gland develops in the floor of the mouth where the tongue is there. The anterior two-third and the posterior two-third, that is the place, the junction where the thyroid gland develops. And during its fetal growth, from the floor of the mouth, the thyroid gland descends down into the front of the neck. During the descent, if there are any thyroid tissue that is sequestrated in the pathway, that can sometimes function, even though you take off the whole thyroid gland.
Right. Okay. Well do, Prof. And one last question, Prof. And this is really on if we have hypothyroid or hyperthyroidism, is it more likely that we'll develop thyroid cancer? I think Prof spoke about this slightly earlier as well, ladies and gentlemen, about the relationship,
yes,
if there is one.
Yeah, one of the things is, you see, there are certain areas in the world where there is an iodine deficient areas. And in these iodine deficient areas, then you tend to get a slight enlargement of the thyroid gland because the thyroid gland has to work much more to produce adequate amount. Long-standing iodine deficiency areas, they have got a tendency of developing follicular cancer of the thyroid gland.
Prof, is there anything that you can share with our viewers in terms of any kind of preventive measure for thyroid cancer? Is there something that we can do to kind of avoid getting it?
The take-home message for me today, especially on today is a World International Women's Day. And as we know, as I mentioned to you, that thyroid cancer and thyroid problems are more prevalent in women than in men. My take-home message is any person who has got a thyroid nodule, even though it is painless, even though the function of the thyroid gland is normal, should be evaluated. They should see a doctor and get it assessed.
Right. Will do, Prof. And I think that's the biggest take-home. For a lot of Malaysians, we tend to take it very easy. We'll just leave it. We'll worry about it in 6 months' time, 9 months' time. Especially for ladies out there, Prof is kind of given you a very interesting International Women's Day message. So happy Women's Day, but really take care of your thyroid. Thank you very much, Prof. Really, once again, it's been an honor to have you with us this evening, and we hope to see you soon.
Thank you, Dr. Murli. It's been a pleasure to be seeing you to this evening. Thank you very much. Thank you.
That was our first speaker for this evening, ladies and gentlemen, and we had the privilege of having Professor Dr. Mr. MMS Krishnan, Consultant General Surgeon at Assunta Hospital, who's our partner for Cancer and Eye this Monday. And not forgetting, of course, our partners, Roche, who have been instrumental kind of putting this series of sessions together, the Roche Pharma unit, the diagnostics unit, of course, the shared services unit as well. Thank you very much for your support. The next speaker this evening, and I'm sure some people are going to be wondering, I'm sorry, I'm just going to backtrack a little bit. The second speaker for this evening is also a surgeon. There is a whole host of surgeons actually, and we're very privileged as well to have to this evening's second speaker, Mr. Liew Fah Kong. Good evening, Mr. Liew. We have you on board already.
Really?
Good evening, doctor. How are you?
Okay.
Lovely. So Mr. Liew Fah Kong is a consultant general surgeon, also at Asunta Hospital. And Mr. Liew Fah Kong has a long, very illustrious, rich history in managing surgical cases. So again, we will be hearing about a lot of insights from Mr. Liew's very long and illustrious career. And very interestingly, somebody was just asking, Mr. Liew is going to speak to us today about stomas. So it's something about stomas, and people were wondering, hey, what has this got to do really? We all seem to be talking about hormones today. This is kind of a nod to this month, which is Colorectal Cancer Awareness Month. And one of the big issues with colorectal cancer, which is very high in women as well in Malaysia, is the fact that often when you detect colorectal cancer and when you have surgery, invariably there's a discussion about stomas, about resection of the colon and you having stomas. And though not everybody needs to have stomas, a lot of people will be very scared of even going for surgery because they are like, I don't want to have a stoma. So today, Mr. Liew has kindly consented to discuss and share with us the ABCs of stomas and telling you all about stomas in the hope that we can educate you a little better about understanding about stomas, its place in the management of colorectal cancer, and hopefully help you to decide better in view of improvement, cure, better management if and when you or your loved one have to be faced with colorectal cancer. Good evening, Mr. Liew. How are you?
Okay, evening, everybody.
Okay, Mr. Liew, I was just going to start off the session by asking you, and we always kind of have one interesting question to kind of put forward to our guest speakers. Mr. Liew, over your kind of very long experience and the many cases that you have done, if you were to tell us about the most interesting experience that you have had as a surgeon, Mr. Liew, which one would it be?
Wow, every case to me is interesting, Dr. Morali.
Oh,
There's no
exactly.
more interesting or something like that. Most of the cases that you handle, some of them give you a big surprise. Yeah, the most interesting thing is to look forward to the case. Yes.
Right, lovely. So no case is the same, no patient is the same. Everything is interesting. True, Mr. Liew. So, Mr. Liew, I'm going to turn the stage over to you to speak to us about stomas.
First slide. Just go to the first slide. Yes, give it there. Give it. Okay, evening, everybody. Now, I've been asked to speak on something about stomas. Now, a lot of us think that stomas have got to do with colorectal cancers alone, but it is not. This something about stomas, I shall talk generally about stomas in different parts of the body. Stomas you can make in the neck, in the abdomen, and different parts. I should go about talking about stomas using line diagrams, which I discuss in my clinic with my patients when I talk to them about stomas. Okay. Now, let's have a little bit of definition about what is a stoma. A stoma is an opening that is made in a structure in the human body to open outside at the skin level. Remember, it's an opening that the surgeon creates in a structure in the human body. Usually it's a tubular structure. Now, surgeons do something with a purpose. There must be a reason why we make an opening in this structure, right? Now, the different types of common stomas that we have, not only in colorectal cancers, but elsewhere, like tracheostomy, number one, gastrostomy. Then we come to colostomy, which all of us may be very familiar with, and ileostomy. And there's something called an ileal conduit, which is also a stoma, and a nephrostomy created by urologists, and a cystostomy. I shall go into all of this with the diagrams that I use to show patients in my clinic when I discuss stomas with them. Okay, let's talk about tracheostomy. Now, a tracheostomy is an opening made in the windpipe in the neck. Now, if you look at the front of your neck and in front of the neck, and you lift your head up, that is the jaw, and you put your hand down in the middle and put it, scroll down, you will feel the Adam's apple. Below that will be your windpipe and along there. A tracheostomy is an opening made in the windpipe below the Adam's apple, created for the purposes of the following. Now, some patients are unable to breathe. Why? Because when they have injury above here, maybe from accidents, trauma, fractures involved this part that blocks the upper airway, preventing the patient from breathing, like bleeding, smashed mouth, jaw, and also in diseases, for example, head and neck cancers involving this part, which makes the patient unable to breathe using the upper airway. Therefore, the surgeon will need to make a hole in the windpipe so that the patient is able to breathe. The other reason why sometimes we need to make a hole in the windpipe, called a tracheostomy, is when we need to suck phlegm out of the airways. Sometimes phlegm blocks the airways, preventing the patient from breathing, and the lungs will collapse. Some patients are unable to cough out the phlegm because of certain diseases or because of coma. So the surgeon will have to make a cut in the neck, either up, down, or even across. Look for the windpipe and make a hole in the windpipe. And this will be connected to the skin outside so that the patient is able to breathe, or the healthcare worker, provider, can suck out phlegm from below. Okay, now we come to the next stoma that we are discussing. It's called a gastrostomy. Now, gastro comes from the word stomach. Stomy, a hole, is made in the stomach. An opening in the stomach in the upper abdomen. How do we do that? Now let's look at this picture. This is the front of our abdomen. This is a navel. So we can create this opening in the stomach either by the conventional method of cutting open this area like that, looking for the stomach, making an opening in the stomach and stitching it to the skin so that it opens outside. The other way is to use an endoscopic method by putting an endoscope through the mouth and then creating this opening. Now, why should we do a gastrostomy? Now, some patients are unable to swallow because of illnesses. For example, if you have a stroke, We may need to feed you using a tube through the mouth into the stomach. But sometimes this tube cannot be used because after a long time, you may cause erosion of the oral cavity, of the pharynx, and all that. So a gastrostomy needs to be done. This is the hole here. That is from here, you can put a tube into the stomach, and then from the tube, you can pour fluid into the stomach and feed the patient. Now, of course, this needs skin care by the health provider, which all the nurses will be able to do. So this is called a gastrostomy, an opening made in the stomach, in the upper abdomen, for the purposes of feeding the patient who is unable to swallow because of illnesses or diseases. Okay, let's come to the colostomy part. Now, colostomy, colon, colostomy. An opening is made in the large intestine called the colon. Now, this can be in different parts of the large intestine. It can be either temporary or permanent. Picture, please. Picture. Okay. All right, let's look at this diagram that I've drawn for you. Now, this is the large intestine. From the right side of the body, where the small intestines join, it goes up, right across, to the left, downwards, to open into the anus. Let's say I have a patient who has a cancer here, this part of the large intestine. And this cancer has caused a blockage. Now, and the stools that come out from the large intestine, that is here, will need to travel downwards, up here, but unable to come out through the anus because of this blockage. There will be a great pressure built up before the blockage. And the intestine here may rupture, burst, because of the pressure caused by the stools coming out, which is unable to cross this blockage. Now, the surgeon will have to do something to help the patient. At surgery, this part of the intestine, the large intestine, will be resected. Now, this patient has come into the hospital because of the blockage, and the intestine has ruptured or burst, causing contamination of stools and the intestinal contents into the abdominal cavity, which will be rather dirty. So at surgery, after we remove this part, we need to clean up the patient very well. Okay. Now, what happens here? This part is removed. There's no more. How can the stools come out? The upper part that is remaining here will be taken out through the skin of the patient and stitched there as a colostomy. The lower part that remains here will need to be closed. So the surgeon will stitch it up and close the lower part. So this is removed. The upper part is taken through a hole made in the skin, and out here we stitch it to create a temporary colostomy. Why? The lower part that is remaining will be closed by the surgeon. So this temporary colostomy will be kept here until the patient is well, maybe 1-2 months. And then the temporary colostomy can be closed. How? Now, this opening is disconnected from the skin at surgery and then joined back to the lower part like this. So this is called a temporary colostomy because you leave it for some time, and then you can join it back. Okay, what is a permanent colostomy? Permanent. Now, let's take this example of a patient who has a cancer at the lower part of the large intestine at the anus, anorectal area, or the lower rectum. Now, this part we need to pass stools. Stools all come out through this passage, but if you have a tumor here, a cancerous growth, there will be a blockage and your stools will be unable to come out. So what to do? Of course, this patient will see a surgeon. After the diagnosis, the patient goes for surgery. Now, if this part is blocked by the cancer and it is growing very low, you have to remove this area of the large intestine. So the two surgeons will do this operation. One will work from the top at the abdomen. The other surgeon will work at the below, at the anus here. Let's look at the lower diagrams. After the abdomen is opened from here, the top surgeon will dissect from the top along these lines. And the surgeon below will cut around the anus and dissect from below around here. Now, once this part is removed, there will be no more. And then whatever remains is the top of the large intestine that remains behind. So how does this patient pass the stools out? Remembering that this area is no more. So this anus is closed, stitched up, no more. You can't pass motion already. Therefore, the upper part that is left behind, the large intestine, will need to be joined to the skin. The hole is created and stitched there as a permanent colostomy, meaning that you cannot close this, meaning that the stools need somewhere to come out. And this is the area of the permanent colostomy where your stools come out into a bag. Now we talk about ileostomy. Now we should look at this diagram here. The small intestines join the large intestine at this area. The last part of the small intestine is called the ileum. Okay. Now, an ileostomy is an opening made in the ileum, which is the last part of the small intestine. What is the purpose? Let's say this patient has got a cancer of this part of the large intestine. Of course, the patient goes for surgery and the surgeon needs to resect this area. After resection, surgeon will have to join back the intestine. Now, anything that we join back needs time to heal. Now, before this area is healed, you cannot feed the patient because if stools are formed too soon, this area will burst open. Therefore, in order to let this part heal, some surgeons will need to make a hole in the last part of the small intestine called the ileum, and this will be stitched to the skin. There's an opening here called an ileostomy. With this ileostomy, you can feed the patient after large intestine surgery, while the joint that we make heals, without which the patient may need to be starved for several days, maybe 5, 6 days like that. This ileostomy that we make in this part of the body will of course have a bag to contain the contents that come out from here, which will go into the bag. Now, this ileostomy is of course temporary. You can close it maybe a month or more than that, depending on the condition of the patient and what further treatment the patient goes for. Let's talk about an ileal conduit. Now, this is a difficult surgery to do. Usually it's done by a urologist. The purpose. Let's look at this diagram. These are the two kidneys, right and left. The urine flows out through the ureters into the bladder, which is this part. Let's say this patient has cancer of the bladder, and the bladder needs to be removed, taken out by the urologist. After you have taken out the bladder, how is the urine going to come out? You need a pathway for the urine to flow out. So we will take one segment of the small intestine. This is a segment of the small intestine with a blood supply attached. This segment is taken at surgery, and after you have taken the segment, you will notice that there are two openings. One is here, one is here. One of the opening will have to be stitched close. So we close this part. And these two ureters at the lower end will have to be connected to this small intestine segment that we have taken. So we connect it like that. So the bladder, urinary bladder is removed because of cancer. We must find a way for the urine to come out. We take a segment of small intestine with a good blood supply. One end is closed, and these two ureters are joined with this segment of small intestine. Remembering that this end is open. This open end is then stitched to the skin. And from here, the urine flows out and collects in the bag. And this is called an ileal conduit. A conduit is something that, carries something, a fluid out. And after that, the abdomen will look like this. So therefore, this will go into a bag collecting the urine. Next one. So next will be talk about nephrostomy, which is done by a urologist. Now, sometimes the urine from the kidney cannot flow out. Because why? Because maybe you have large stones blocking, which cannot be taken out because of the patient's condition. Or you have ovarian cancer blocking the lower part of the ureter that prevents the urine from going into the bladder. Now, how can we let the urine flow in this case? What do? We can do something called a nephrostomy, which is a hole made in the kidney so that the urine can flow out. So let's say this is the side of the body, the side. With an ultrasound, we can locate where is the kidney. Using that, we can push a catheter into the kidney, and the catheter will sit in the kidney like this, coming out from here into a bag. The purpose is to let the urine able to flow out, because the ureter cannot carry the urine into the urinary bladder because of blockage below from cancers or large stones blocking this area. This nephrostomy is done by a urologist. And of course, the urine, when it flows out, will be collected in a urine bag here. Okay. Now we talk about the cystostomy. Suprapubic is the area I will discuss. Now, cystostomy is a hole made in the bladder so that urine can come out. Now let's look at this diagram. This is the front of the body, and this is the navel. This area is called the suprapubic area. So the location of this cystostomy that we talk now is a suprapubic cystostomy. Let's say, for example, this is the area with this pointer that you see, which is here. All right. Let's say the bladder is very distended, enlarged, because the urine is collected in the bladder, and in a male, for example, is unable to flow out. Why? Because maybe the prostate is big and large from cancer. Maybe it's from prostatic hyperplasia, which cannot be removed. Why? Because maybe the patient has numerous other medical problems that prevents him from having surgery, or the tumor has spread outside below here, making it unable, not amenable for resection. Therefore, you need some relief of the urine. We can make an opening in this area called a suprapubic area, and we insert a catheter inside. After that, there's a balloon in the catheter which we blow up, and then this prevents the catheter from slipping out, and the urine comes out from the urinary bladder into this suprapubic catheter and into our urine bag. Okay, go to the first slide. Huh? So, in this brief discussion that I have, talking about something about stomas, we have gone through the numerous stomas that we can create in the body: tracheostomy, gastrostomy, colostomy, which you're quite familiar with, most of us, ileostomy, ileal conduit, nephrostomy, and cystostomy. Okay.
Thank you so much, Mr. Liew. I think one of a couple of very interesting points that you shared with our viewers today, including the fact that the stoma is not really just all about the colostomies. And I think thank you very much for kind of going through with us all the different kind of different stomas that actually a lot of us kind of face in daily life. We see friends, family members coming up with these things. I think we're quite confused about the different terminologies around it. Hopefully this has been kind of enlightening and helpful for them as well. Mr. Liew, if you're okay for time, there are a couple of questions that have been put forward by members of the audience. Are we okay with taking that, Mr. Liew?
Yes, of course, yes.
Lovely. Okay, there's one question on, are all stomas permanent? And when we put in a stoma, does the doctor always have a way to reverse or put the question is close the stomas, so I'm just putting it back as reversible.
Okay, so there are so many types of stomas, that we have discussed just now. The colostomy one, I've already gone into several pictures that you can see. Some are temporary, some permanent. Tracheostomy. Some tracheostomy are temporary. When the patient is able to overcome the upper airway, it will close by itself. Usually you don't have to close it back. And if the tracheostomy is used, created to suck, for example, phlegm and all that, once this function, like removing the phlegm out, the patient is able to breathe normally, then this will close by itself also. You don't have to do anything. Now, gastrostomy. Now, because the patient is definitely unable to swallow, therefore the gastrostomy is usually permanent one, usually. Unless you can close it if the patient is able to swallow again. Otherwise, it is not. Ileostomy, we have discussed, it is usually a temporary one, which we can close back. Ileal conduit, of course, is permanent. Urine need to flow. You don't close an ileal conduit. A nephrostomy is made sometimes temporarily, sometimes permanent, depending on the patient's other conditions, which you need to discuss with the urologist. And of course, the cystostomy, well, some of it is temporary, some permanent. We need to discuss further conditions of the lower part, like prostate and all that, before we can discuss whether we can, remove the cystostomy or not. Yeah. So individual cases need to be go into before you can tell, oh, let's close this. But we know that in colostomies, the permanent colostomies cannot be closed. Ileal conduits cannot be closed. All right. Okay.
Well, thank you, Mr. Liew. There's another question on is there a higher risk of infection with a stoma? Is there any special continuous antibiotics that we need to use when we are having a stoma? And I think this is more for the GI stomas, Mr. Liew. I mean, the question seems skewed that way.
Stomas. Okay. Now, colostomies. Colostomies, if you create a good colostomy with a nice fit of your apparatus, for example, the bag, the plate on your body that collects the effluent, that whatever flows out properly, then it's very good. You don't have much problems. If the colostomy is created in a patient who is maybe obese with overhanging fat in the abdominal cavity, near to scars or bony prominences, which you cannot put the base plate properly, or your colostomy has retracted, then it is difficult to control the effluent, whatever comes out, and it flows onto the skin, creating excoriation and sometimes infection. All right. Ileostomies, of course, is more fluid than colostomies. And if the effluent, whatever flows out from the ileostomy, is not collected well, if the ileostomy is not created well, and the apparatus that you fit on the ileostomy to collect the effluent is not good, then of course it faces the same problem. But this one is more, erosive because of the contents that comes out from the ileum. It flows onto the skin. Excoriation is greater. In ileal conduits, of course, you have to put a nice fit. Otherwise, the urine will contaminate the surroundings. Now, infection of stomas do happen, but not so often as people think. It's not a common thing to have. Yeah.
Right. Well done, Mr. Liew. And then there's one more question, and I think this is the final one. Is there any way when we do surgery of the abdomen and we have to remove colon, small intestine or large intestine, is there a need to ever put a stoma? Can we not do without a stoma? I think Mr. Liew has explained this in a bit of depth, but I think maybe Mr. Liew would like to put in another few comments for this as well, sir.
Okay, now let's talk about colostomies. If your condition requires a permanent colostomy, of course you need to create a permanent colostomy. If the tumor is low rectal, very low, near the anus, you can't help it. You need to put a permanent colostomy. But if the tumor is elsewhere in the large intestine, after resection, you can create a temporary colostomy like we have already discussed. And then when this area that you have joined has healed, you can close back the colostomy. That is a temporary colostomy. Then, of course, ileostomies are created as for the reason that I've said. Ileostomies are usually created and then not permanent. You can put it back later.
Will do. Thank you so much, Mr. Liew. I think what we made a big mistake with the title. We should not have called it something about stoma. I think what Mr. Liew has given us this evening is everything about stomas. So as much as I was saying earlier, a lot of people are very confused with stomas. You live very fearful of stomas. A lot of people refuse surgeries because they think you're going to have stomas. Hopefully, I think Mr. Liew has shared with us very extensively what stomas are all about, what we can use stomas for, why are they helpful, and the different types of stomas, and as well as kind of to clarify to everyone, like what are the role of stomas kind of in surgical management. So thank you very much, Mr. Liew. Again, a pleasure having you with us this evening. So we will see you soon.
Yeah. Thank you very much.
Right. As we finish, Mr. Liew, could I ask you for what maybe a message to take away for our viewers tonight?
I hope that all of you have got a general view of something about stomas. Something. Thank you.
Thank you very much, Mr. Liew. Good night. Ladies and gentlemen, that was our second speaker of this evening, Mr. Liew Fah Kong, who is a consultant general surgeon at Assunta Hospital. And this evening, Cancer and I, this segment is in partnership with Assunta Hospital, and of course with our main partners for this entire series, Roche, Pharma, Diagnostics, and Shared Services. And I was telling you, tonight is a surgical series. We've had 2 consultant surgeons, and the third eminent speaker who will join us this evening is also a surgeon, and we're going to ask him really what is the difference between his kind of surgical specialty and that of the general surgeon is. We're very fortunate to have with us this evening Dr. Ragu Shanmuganathan. Good evening, doctor. How are you?
Hello, good evening. I'd like to thank you for having me.
Oh, lovely, doctor. It's always a pleasure having you on board. And just kind of to open the betting, or close the betting, as it were, in this sense. What is this? Why are gynae surgeons? And what's a gynecological surgeon? And why are you all not misters? Wow. 3 very sensitive questions.
Well, gynecological surgeons are basically surgeons who deal with the female genital tract, and we deal with the cervix, the uterus, the ovaries. Although they come very close to the bladders and the bowel just sitting behind, we tend to sort of confine ourselves to the female genital tract. As to why we called Mrs. I think in the past history, to become a gynecological surgeon, you have to do general surgery first. But the College of Obstetricians and Gynecologists, they sort of pushed away from the College of Surgeons, and hence to, I think, differentiate ourselves, we decided to carry on calling ourselves doctors. So I would put it as that, although there'll be many funny stories about why and why not.
Sure, doctor. And ladies and gentlemen, for the uninitiated, Dr. Ragu is a gynae oncologist who really deals in oncologies of the gynecological tract. And he's here this evening to speak to us about not so common cancer of the gynae tract, at least in the social perspective. We don't hear about it as much. But Dr. Ragu is here to kind of open our eyes a little bit to these cancers and the fact that they continue to be kind of a big part of gynecological cancers. So, Doctor, I would like to turn the stage over to you, please. Go ahead.
Thank you very much once again for having me, Dr. Murli. I appreciate the opportunity to have a talk. The first thing I'd like to state very clearly is that uterine cancers are becoming more common. They're becoming more widely diagnosed, and considering that women are living longer nowadays, the cancers which tend to occur at a later stage are becoming more prevalent, and uterine cancer is certainly one of them. The uterus essentially serves 2 purposes. One purpose is to have its periods on a regular basis from the start of menarche, the start of periods, as well as to end upon menopause. During that particular time, it has the capability of carrying a baby, to which most people expect of the uterus. And following menopause, it seems to be a redundant organ. But that's not entirely so. It does still play a role in the functions of the ovary, and to produce some of the, or to give some of the blood supply to the ovary to let it continue functioning and producing endogenous hormones for at least a short period of time after menopause. However, as I said, as women are growing older and are living for longer periods, there are changes that can occur within the uterus, some of which may be benign, some of which may become cancerous in the future. So the word uterine cancer is a little bit of a general term for a malignant neoplasm arising from any part of the uterus, which includes the endocervical region, the region of the cervix, the lower part of the uterus just above the cervix. And depending on which site it arises from, the nature of its progress is different. Unfortunately, with uterine cancers, we do see a fair bit of variation in the cell types, the histological parts, and that makes it very difficult for treatment in the future, because some of the treatment may not necessarily be as radical as the others. So here's an example, if you look at a picture of a uterus with growth within the endometrial cavity. This is the most common presentation of endometrial cancers, where the growth arises from the inner part of the uterine wall. And if you notice the part where the arrow is pointing, that's the myometrium, the muscular layer of the uterus. We do have malignant neoplasms arising from there as well, and very seldom on the surface of the uterus. The lower part here is the endocervical region. The significance of the endocervical region is tumors, even though they arise from the upper part of the uterus, if they involve the endocervical region, they behave like cervical cancers. Now, why is there a difference? It's because of the lymphatic flow. The nature of spread differs if the cervix is involved compared to if the uterine corpus is involved. And they tend to be glandular cancers. We call them adenocarcinomas. And the method of spread for most of them is through the lymphatic channels. Unfortunately, if it were to arise from the muscle layer, what we are worried about is something called a sarcomatous change, which is a different form of cancer, which has a very, very aggressive local spread, and it does spread to the blood vessels itself. So the nature of treatment becomes very much more different. So if you look at the Malaysian burden, we are still looking at breast cancer being the most common, colorectal cancers coming a close second, and cervical cancers coming third. But we do see that the corpus uterus, the endometrial cancers, are also starting to become more evident because we are actually picking them up. The problem with the endometrial cancer is, unlike cervical cancers and breast cancers where you can do, breast pathologies where you can do ultrasounds and mammograms, and cervical cancers where you can do pap smears and so on, endometrial cancers have no clear screening method. That means you can't pick them up before they become cancer unless they've actually shown some symptoms. So the first thing you must understand is we can't pick them up before it happens. But what we do have to be aware of is the risk one faces according to when we're looking at genetics, when looking at lifestyles and hormone use, awareness of the signs and symptoms, which means changes within a normal lifestyle pattern, which gives us an example or gives us a reason to believe or to worry about cervical or endometrial pathologies, awareness of where to go and seek for treatment. And of course, the final one, empowerment of choice, where the choice of what you do to the uterus also becomes important. It's strange that at times we actually depend on the husband's choice or husband's opinion when we offer the choice of management. So some of the things that we do have to understand is there are two types of endometrial cancers related to the endometrium, which is the most common one. One is called a type 1 endometrial cancer, one is a type 2 endometrial cancer. The type 1 tends to occur later on in life, and that's, you're looking at the end of the 6th decade and early 7th decade. They tend to be much more hormone related, whether it's exogenous, something that you've taken orally, or whether endogenous, something that's been produced within the body. And they tend to be slow growing, low grade histological types, which means they're pretty much lazy cancers. And these are the cancers that respond well to treatment. They respond well to surgical resection, and they tend to be a much easier cancer to treat. However, there's also a second type, which tends to be more genetically inclined, and we see them at a much younger age. So for instance, if I were to see a stage 2 or stage 3 cancer patient of a 60-year-old, and I see a stage 1 cancer of a 30-year-old, I'm more worried about the stage 1 cancer of the 30-year-old, because they tend to be of a higher grade. And the types of cancers, for instance, we talk about papillary serous cancers or clear cell cancers or carcinosarcomas, they tend not to respond to treatment as well as the type 1 cancers. And that's where the biggest challenge lies. The fact that we are now finding these kind of cancers in much earlier group, and the outcomes are not as good as we'd like them to be. So what are the endogenous sources of estrogen? Obesity. So for instance, a fat cell in the peripheral part of your body, they do convert androgens, male hormones, into estrogens. And the more fat cells you have, the higher the chance of this changes occur. So these elevated levels of estrogen, they do react, or they do influence the endometrial lining, which causes them to first start becoming bigger, then behaving differently. So anywhere from hyperplasia, simple, to actually frank cancer. And the other one is anovulatory cycles. So patients who are actually having their cycles without actually producing the eggs that would result in the elevation of progesterone, which protects the endometrial lining. Finally, estrogen secreting tumors. We always believe that an endometrial cancer arises from the endometrium. It may be so, but it may not be sort of influenced or instigated by the actual changes within the uterus. They may be an extra uterine stimulus, and majority of that comes from an ovary, which produces estrogen. So you have ovarian cancers such as granulosa cells secreting tumors, which tend to cause a reaction in the uterine wall itself. Some of the risk factors that we'd like people to know, and especially the ones written in red, are the ones that we really want to we want people to pay attention to, is early menarche. At an earlier stage, you start your periods. Late menopause, and a later stage where you stop your periods. That means there's a greater duration of exposure of estrogen arising from the ovaries to the uterus. Infertility or nulliparity, lack of having children. Obesity, as I explained earlier. Treatment with tamoxifen. Now, a treatment plan for breast cancer would include something called a selective estrogen receptor modulator, a SERM. And the most common one that's used is tamoxifen. It has a when we say selective, it has different functions. It blocks the receptors, estrogen receptors in the breast, resulting in a decreased reactivation of cancer cells. However, it stimulates the estrogen receptors in the uterus, which means it starts causing the cells to become active again. And that can lead to, once again, hyperplasia, a precancerous lesion. And if unchecked, it can lead to actually cervical, to endometrial cancers as well. The use of hormone replacement is, I think, very, very well documented. There's a WHI study which came out in 2001, along with a million women study, which suggested that prolonged estrogen exposure through hormone replacement actually increases the risk of endometrial cancers as well. Animal fats, diabetes, certainly age greater than 40 years. Unfortunately, that's very age discriminative. However, we do say that almost with every cancer, age plays a role. Caucasian women. Now, family history of endometrial cancer or hereditary non-polyposis colon cancer. So there is actually a syndrome called Lynch syndrome, in which case colon cancers, lung cancers, and uterine cancers go very close hand in hand. And they tend to be very early cancers. Sorry, when I say early means they tend to appear at an early age. They tend to be a lot more aggressive as well. So with the use of genetic assessments now, we're starting to find patients who have these deletions in their genes, and we talk to them about risk management. Sometimes the risk management does include prophylactic hysterectomy. It's not a very easy thing to accept, but sometimes if you do have a really good counseling session and the patients are open to options, they do consider this as an option.
personal history of breast or ovarian cancer, and certainly prior radiation for pelvic cancer. So a patient who has pelvic radiation for cervical cancer or even colorectal cancers, you can have changes or damage to the endometrial cells, which can in the future lead to cancer, endometrial cancers as well. Some of the symptoms which we'd like people to understand is non-menstrual bleeding. That means bleeding in between your periods, and especially post-menopausal bleeding in the type 1 cancers, where patients who are expecting not to ever have periods again suddenly come in with a bleed. Now, a lot of times maybe they don't pay so much attention to it, or they do wait a while to see whether it bleeds again. I think even after the first bleed, it warrants a good assessment and a proper assessment of it. Heavy bleeding is one of the symptoms. So what we'd suggest is any change in the menstrual cycle, which may lead to a heavier bleed, would warrant an assessment. It doesn't mean that we're going to find something obvious, but certainly we'd be worried about that, especially if you have history of being diabetic or perhaps being on the larger side, or even a family history of cancers as well. Dysuria is a very vague term. It basically means burning urine. And as in fact, Mr. Liew had suggested earlier as well, if the bladder is involved, considering that the uterus is sitting just below the bladder, you do sometimes see a local metastatic deposit within the bladder, and that may give you the first sign that something is going on. Pain during intercourse, obviously, it's a very subjective point, but perhaps if it's abnormally painful compared to, say, previous episodes, then that also warrants an assessment. Certainly an enlargement of a mass in the pelvic region, weight loss, unexplained weight loss, and back pain, considering that the uterus is also attached to the backbone. So an increase in size leads to stretching of the uterosacral ligaments, which leads to back pain. Now, how do we actually go about detecting the possibility of cancer? The simplest thing is, simplest way is doing an ultrasound, and hence why we do advise patients to have at least yearly reviews, where you can do an ultrasound to just look for subtle signs that something may be going on. The main point that we are looking at with an ultrasound, especially transvaginal ultrasound, is the endometrial lining. We have a certain level of safety between 4 millimeters to about 8 millimeters. But in the presence of abnormal symptoms with an enlarged endometrial lining beyond the 8 millimeters, we would want to take that seriously and consider an assessment of the whole situation to see whether we can find anything wrong. Hysteroscopic assessment, it remains the gold standard. That means we're putting a camera into the uterus, having a look inside, and sometimes identifying a focal area which we can biopsy, or even identifying large areas where a curette is actually done. So samples can be taken to the lab and the histological tissue the histological report being produced. So using these two methods, we first have a suspicion, and then with the second method, we have confirmation of whether disease or pathology exists. The treatment principles, it always depends on, number one, the staging. Certainly also the staging would include the aggressiveness of the tumor, the stage of spread, as well as the the lymph node involvement as well. And that includes, once again, the hysteroscope to get the tissue, perhaps a CT or an MRI to look at the invasion of the tumor into the muscle of the uterus or into the endocervical region, as I explained, and this also would include the nodal status. A PET scan can be done, especially if you are worried about very frank distant metastasis, where it tells you about adjuvant treatment following the procedure itself. Certainly, surgical resection remains the mainstay of treatment of endocervical cancer, and obtaining good margins, of endometrial cancer, I apologize. Obtaining good margins is essential. This is especially essential in the type 2 cancers, where you're looking at carcinosarcomas, a combination of a sarcoma and a carcinoma. Papillary serous carcinoma, which behaves, although it's an endometrial cancer, it behaves like an ovarian cancer. So the treatment or surgical resection changes from a simple extended hysterectomy to an extended hysterectomy with periaortic and pelvic lymph node dissection, as well as an omentectomy. And certainly if it's a type 1 cancer, you do not have to be as aggressive with the margins as long as you achieve the right margins. If you are having an endocervical involvement, you treat it like a cervical cancer where a Wertheim's or Okabayashi hysterectomy done. You're looking at a type 3 to type 4 cancers, type 4 resections, which are fairly radical in the pelvis. Now, once we've got the staging, we do not assume that a surgical resection alone would be sufficient. Even with as low as a stage 1B tumor, we do recommend adjuvant treatment, which includes essentially radiation therapy, which would include external beam treatment, even internal or intracavitary radiotherapy, as well as, in some cases, chemotherapy as well, especially if the nodes are positive. We can only sample a certain number of nodes. We can't sample the entire lymph node system of the whole body. The assumption is that if one node is positive, there is a possibility that other nodes are going to be also positive. And the radiation therapy, while it can treat the localized area, it is not going to be able to treat the entire body. So chemotherapy tends to offer a more systemic management plan. Complementary care. Now, in the current age, we're not necessarily confining ourselves to just purely that old adage of surgery, radiotherapy, chemotherapy. I think we do have to accept that immunotherapy, nutritional therapy plays a very strong role in improving the immune system or even improving the response of the patient to treatment. So the additions of vitamin C, zincs, and things like that, they are starting to come into the fore of management along with the standard management as well. So I think it's something that in the future is going to come in as a complementary treatment plan for all cancer patients. It's not just going to be confined to uterine cancers. And I think that's something that we would want to look at in the future. So that essentially is a simple discussion about how we deal with uterine cancers and all that. And the most important thing I think we'd like to put across is that people have to be aware that there are changes within the body which may give you a clue of something abnormal happening, and that those kind of changes need to be taken seriously. And a simple assessment should at least be available for the patients as well. We don't want to assume that everything is normal and that we can ignore certain signs. I think that's the most important thing. We'd rather treat a patient who is at an early stage than at a later stage. And that's no doubt. Yeah. So Dr. Murali, I think I've tried to be as simple and as concise as possible. So I was just wondering whether that would be that's acceptable or okay for you?
It's fine, Doctor. Thank you so much. What we have some questions. If you're okay for time, Doctor. Are you
yes,
okay
of course. Go ahead. No problems at all.
Lovely. Well, this is some questions that come in. The first, of course, is if you mentioned earlier about there not being any sort of screening for uterine cancers. However, is there a role that could be played by medical checkups? Should women go for medical checkups? What should they be looking out for in terms of uterine cancer?
I think that's a fantastic answer, because I was telling you a little bit, a little anecdotal tale about the pap smear. A lot of patients, when they do come in with endometrial tumors, they would have said that, you know, I had a pap smear done last year and they found nothing. Now, the funny thing is, George Papanicolaou, who came out with the pap smear, intended for that pap smear to actually look for endometrial cancers. It was his cytologist who told him that the cells that he was actually sampling did not come from the endometrium, but it came from the cervix. So they changed the whole thing to a cervical cancer. Now, the cells that are picked up in a pap smear are only ones that are extruded from the uterus or from the cervical wall. So not necessarily representing what's going on higher up in the uterus. So that's one thing that everybody assumes, that pap smears are going to help them find out all these things. Unfortunately, for endometrial cancers, pap smears don't. So that's the first thing. It is always a good idea to have a checkup, essentially because breast cancer is being so common. A proper review of a women's genital tract makes a lot of sense, especially on a yearly basis. So hence, while we're doing the pap smears, we tend to also do a simple scan just to have a look and see whether there's something that we could pick up incidentally. And that makes sense. That makes a lot of sense, because we know that in the evolution of cancer is not immediate. It does take time. So sometimes if we get a chance to pick up something pre-cancerous, it may give us a chance to treat her prior to even any onset of cancer, malignant change. So yes, a checkup certainly makes sense.
Okay, got it, doctor. Second question is on am I likely to get uterine cancer if I'm vaccinated against HPV?
Unfortunately, no. The uterine cancers are not dependent on the HPV infection. HPV purely and almost exclusively affects the cervix. But of course, you know, the anorectal region, the nasopharyngeal region and all that, yes, but not uterine cancers. No, I'm afraid not.
Right. Okay. And then the third question was, I think, something that you were alluding to slightly earlier as well, doctor.
Yeah.
And this is on whether there is a genetic relationship between breast cancer, uterine cancers, and a family history.
Well, breast cancer and ovarian cancer, I think that relationship is of no doubt now. We know the BRCA1 gene and the BRCA2 gene mismatch occurs. However, with uterine cancers, it tends to be more closely related to colorectal cancers as well as lung cancers with regards to the Lynch syndrome. So you get a HNPCC sort of a picture there, and with that, you tend to find those patients being more if you have a family history of colon cancer, lung cancer, I'll be more worried than breast cancer and uterine cancer.
Breast cancer and son cancer. No, this one is I think quite an interesting question as well. Sure. Does uterine fibroids predispose me to having uterine cancer?
The uterine fibroids are not immune to cancerous change, but the actual incidence of it changing from a benign lesion to a malignant lesion is only 0.2 to 0.5%. They don't change to the normal endometrial cancers that we would think of, but they have sarcomatous change. So sarcomas are tumors which behave slightly differently from adenocarcinomas. They tend to have a very distinct local spread, but also a very profound hematogenous spread. That means spread through the blood vessels as opposed to the lymphatic vessels. So you get a very, very aggressive local spread. And hence, with leiomyosarcomas, we are very aggressive with the surgical resection because the sarcomas don't respond to radiotherapy or chemotherapy as well as the adenocarcinomas. So it's not just about the word cancer, but the type of cancer also plays a role in management. So yes, there is a small risk, but it's 0.2 to 0.5% only. So it's rather small.
Got it, doctor. There's another question on if uterine cancer is diagnosed early, do I need to remove my entire uterus?
We would certainly recommend a hysterectomy as the primary surgical option for the patient. Yes, certainly. Having said that, one question that I would answer is this, and this is a little bit of a sort of experience as well. I have had another gynecologist who was only 33 years old when she presented to me a long time ago, and she was diagnosed with well-demonstrated endometrial adenocarcinomas, endometrioid adenocarcinomas. So it's a stage 1 diagnosed on a hysteroscopic assessment, but it was a grade 1 disease. That means a very early, very, I would say not an aggressive tumor. And she was very adamant that she wanted to get pregnant. So when we talked to her for a while she was making up her mind, we put her on very high dose progesterones, which counteracts the estrogen activity. And every 3 months, we had to do a DNC to sort of thin out the endometrium. And we talked about her options, and we actually dealt with a fertility specialist, although I do not in any way recommend this. This patient, knowing her risk, and she's a gynecologist herself, opted to have an IVF done, pregnancy. She had a pregnancy. During the cesarean section, I also removed the uterus. That was the understanding, and that was the agreement. And when I removed the uterus, we actually found foci of grade 2 endometrioid adenocarcinoma. So there was a progression because of pregnancy. So the answer is yes, I would say that if you are diagnosed with endometrial cancer, a resection of the uterus would probably be the best idea. Yeah. And now, having said that, one more thing, sorry, I'll just add on to that. There are patients who are not able to actually undergo surgery for various reasons. There may be other medical reasons for surgery not being an option. They are sometimes advised for radiotherapy as well, but we also put in a long-standing progesterone pin that actually releases progesterone every day over a period of 5 years called a Mirena coil. But nevertheless, that patient is assessed normally every 3 months to ensure that they are not showing any signs. Yeah,
progressing. Right.
Yeah.
Right. This one I think is and I'm going to kind of wrap this up with this question. Sorry, doctor, I seem to be getting quite a lot of questions.
No worries.
So this one is from I think a survivor. This is for a breast cancer patient who is taking tamoxifen.
Yes.
Would an annual pelvic scan lower risk?
I think if she's asked that question, she knows the answer, and that's a very good question. The answer is yes. Most oncologists who are dealing with patients with breast cancer who are on tamoxifen, I think that anytime they do have any symptoms of bleed, they do actually refer them on to a gynecologist to have a proper assessment. But if they do it on their accord, I think that makes very, very good sense.
Sense as well. Right.
Yeah.
Exactly. Okay, doctor, thank you very much, and thank you for giving us a significant part of your evening today.
No problem.
Hopefully, we've done a bit of our job in terms of educating our viewers and our colleagues out there on uterine cancer and how. I mean, it's the new cervical cancer. If I could.
Well, yeah, it is. It is. The cervical cancer vaccine is doing its job.
Yeah.
Certainly.
Yeah. Yeah. So it's time for us to look out a little bit as well. And I think Dr. Ragu kind of pointed out about how obesity is one of these drivers, and we're not getting it exactly smaller, are we? So that's another reason for us to be a little more careful and to watch out a little more. So thank you very much, Doctor, for joining us this evening. And I'd like to ask you whether you would be able to leave us with some takeaways for tonight.
Take care of your health. Take care, distance socially at the moment until things get much better. But always be aware of the choices you have. I think that's the most important thing. I think the main hindrance to us hindrance to a patient getting care as fast as possible is the choices they make. So always have that in mind, that you have choices, you have avenues to go to. If you're worried about anything, please just get an opinion. That's all. That's the most important thing.
Right. And with that, we'd like to thank you very much, Doctor. Very good evening. See you soon.
No problem.
And we will end this session of Cancer and I, ladies and gentlemen. This evening, we've been very fortunate to have 3 esteemed physicians from Assunta Hospital. We started off with Mr. MMS Krishnan and Mr. Liew Kong, and currently now Dr. Ragu Shanmuganathan. And our partner for this session of Cancer and I has been Assunta Hospital. And we'd like to thank Assunta Hospital for their support, as well as our partners, Roche, for their support in putting this series together. We'd like to bring this segment of Cancer and I to an end this evening, and hope to see you soon. Take care. Good night.